Welcome to Module 4, Effects of Immobility. In this module, you will learn about the skeletal system, joints, bones, different disease processes, and how the nurse can take care of a patient with immobility issues. The skeletal system is comprised of bones, bone marrow, osteoclasts, and osteoblasts. The bones are our outer shell and spongy inside. There are 206 bones in the typical adult. The bone marrow creates red blood cells located in flat, short, and irregular bones. Osteoclasts break down old, damaged tissue, and osteoblasts repair bone and build new bone. Here is a couple pictures of some joints. So articulate joints, there's three different types. Synarthrosis are immobile joints. They're like the sutures between the cranial bones. Ampharthrosis are limited movement or pubic vertebral joints. And diarthrosis are synovial joints. These are free movable joints. Joint disorders in the ball and socket, condyloid, gliding, hinge, and pivot, or saddle can be a result of trauma, illness, and injury. When we consider immobility, we have to consider that mobility is the freedom and independence in purposeful movement. Mobility refers to adapting to and having a self-awareness of the environment. Functional musculoskeletal and nervous systems are essential for mobility. Immobility is the inability to move freely and independently at will. The risk of complication increases with the degree of immobility. We will discuss this in further. Some of the joints that are involved with immobility are ball and socket, the shoulders and hips, condyloid, the wrist, gliding intervertebral joints, hinge, knee and elbow, pivot. They're the vertebrae or base of the skull, and saddle. Some of the muscles involved are skeletal muscles. They're the muscles that move the joints in the bones. Smooth muscles, they're part of organs such as the digestive tract, kidneys, GU tract, circulatory system, arteries, intestines, and GI tract. Cardiac muscle has an ability to contract spontaneously and helps the ventricles contract. The nervous system is composed of the autonomic and autonomic movement key concepts that we have to understand is activity, movement caused by contraction of skeletal systems. Exercise is a subconcept of physical activity. It is planned, structured, and repetitive. Fitness is the ability to carry activities of daily living without fatigue and weakness. Body mechanics are important. Describe how we move our body. Body alignment, coordination, balance, and joint mobility all take play in the mobility or immobility in a person's body. Body mechanics involves coordination between the musculoskeletal and nervous system and use of alignment, balance, and gravity or friction. Movement depends on the intact skeletal system, skeletal muscles, and nervous system. Assessment focuses on mobility, range of motion, gait, exercise status, activity tolerance, and body alignment while standing, sitting, and lying. Factors that may play into affecting mobility are alterations in muscles, injuries in musculoskeletal system, poor posture, impaired central nervous system, and health and age status. Body alignment and posture, the place of the spine is important for body alignment and posture. So if the spine is in a neutral resting position, that is considered good posture. Allow the bone to align, reduce stress and fatigue. It reduces stress and fatigue on muscles and joints. Ligaments can work efficiently in this posture. Causes of poor posture: accidents, traumas, and falls. Careless sitting, standing, or sleeping. So, for instance, sitting with your legs crossed, standing with bowed legs, or sleeping on your side can cause problems with posture. Excessive weight, foot problems or improper shoes, occupational stressors, poor sleep support, poorly designed workplaces, visual difficulties, weak muscle or imbalance, skeletal misalignment, or malformation. Maintaining proper posture. So avoid standing in one position for long periods of time. Do not lock your knees when standing. Keep your core tight. Do not bend forward at the waist or neck. Sit at a comfortable height when at a desk. Do not wear high-heeled platform shoes for long periods of time. So not to slump when sitting, sit in an erect posture. Sit close to your workstation. Use back support, and sit with your feet flat on the floor. Balance is required to keep body alignment. As you can see, the little picture, the diagram of the person, there's a line of gravity that should pass through the center. Imaginary vertical lines drawn from the head through the center of gravity. Gravity of center should be close to the base of support, below the umbilicus, at the top of the pelvis. Base of support is what holds your body up. So the base of support is your feet. Avoiding injury. When working, you want to always place your center of gravity closest to the base of support. Stand with your head raised, buttock pulled in, abdomen tight, chest high, shoulders pulled back, and feet wide. Always remember keeping your feet wide sets for a good platform for your center of gravity. The lower the center of gravity, the easier to maintain balance. Coordination comes through three different parts of the brain. So the symphony between the nervous system and the musculoskeletal system is coordinated through the cerebral cortex, the cerebellum, and the basal ganglia. When you have a patient that may need to perform range of motion exercises, there's two different types. Active range of motion is independent joint movement. The patient does the work for themselves. Passive range of motion is dependent joint movement. It's when you're going to assist the patient through the range of motion. Joint movement. If you think back to your physical assessment class, you learned these already. There's flexion, like flexing your bicep, extension, where you extend the muscle to its full length, abduction, when you're moving the extremity away from the body, adduction, you move the extremity towards the body. Circumduction is when you are allowed full range of motion, the extremity can move in a circular motion front to back. Internal and external rotation is often done with the palm of the hand. In opposition is finger to thumb for each finger. Developmental age does make a difference with your assessment. So when you're assessing, you need to make sure that you assess to the neuromuscular development age. For instance, a newborn can move extremities but cannot get places until the development continues. When you're considering the developmental age, as we age and become older, older adults have alterations in balance, resulting in major fall risk. They have a steady loss of bone mass, resulting in weakened bones. They may have decreased coordination, a slower walk with smaller steps, alterations in functional status, and they may have a increased dependence on staff and family, which can be long-term. When we're considering an adolescent, imbalanced growth spurts may alter their mobility. It may cause alterations in family or social systems and alterations in job identity and self-esteem. You ever think about some of the children or adolescents that are growing and they are growing rapidly and become a lot taller than the rest of their peers? This could result as a self-esteem issue, and that is the third hierarchy on Maslow's. Sadly, in the US, obesity has increased drastically. Teenagers and children due to more sedentary lifestyles. Older adults are at more risk for wasting and mobility consequences. Some things that we have to consider are their nutritional status. Unhealthy eating habits, unhealthy diets increase the risk of disease. Diseases related to heart and metabolism are increased when unhealthy nutrition is present. Undernutrition, a balanced diet causes delay in body tissue repair, muscle wasting, fatigue, and decreases activity level capacities. They have a reduced energy output. Lifestyle choices also can create immobility, selecting a sedentary lifestyle, and some cultural beliefs. A person raised in a modest culture would not want to use a swimsuit during water exercise. This is a type of cultural belief that may prohibit them from exercising in groups or in public. Stress. High level of stress is related to fatigue. Exercise can help reduce stress, which helps energy increase, and using exercise or activity will help the patient recover faster. Environment. The environment plays a role in mobility and immobility. So environmental factors can affect exercise and activity. Pollution or exposure of allergens, finances, neighborhood conditions, weather, and support systems. Here are a couple congenital abnormalities of the musculoskeletal system. Syndactylism is fusion of one or more fingers. Development dysplasia of the hip is a hip dysplasia due to femur abnormalities. Foot deformities are club foot. This can affect walking. And scoliosis, lateral curvature of the spine. Osteogenesis imperfecta are brittle bones that fracture easily. Acroneoplasia is dwarfism. Paget's disease is an increased bone loss, resulting in pain and pathological fractures. Vitamin D and calcium create porous bones. Prolonged deficits can cause bowed, retard growth, and frequent fractures of the long bones. Diseases affecting joint mobility are rheumatoid arthritis, systemic autoimmune, causing chronic inflammation of the joint and connective tissues. Osteoarthritis is a loss of cartilage in the joint. Ankylosing spondylitis is a chronic inflammation of the joint, mainly in the spine and sacroiliac joint. And gout is inflammation response to high level of uric acid. Gout, these people have forms of tophi or white nodules that form in the synovial fluid. When we talk about RA, it causes pain, deformity, fever, fatigue, weakness, weight loss, and loss of function. It mostly happens in midlife or mid-age and females. Osteoarthritis causes pain also, stiffness, crepitus, which is different than RA, and aggravated by weight bearing and joint use. So if you think about the difference between osteoarthritis and rheumatoid arthritis is osteoarthritis, the bone itself is decaying, and when the joints rub together, it makes a grating sound on movement. This also happens most frequently in females. So both RA and OA are female genetic traits. Some diseases affecting bone density are osteoporosis. So osteoporosis is a decrease of total bone density when osteoclast activity is higher than osteoblast, most common in females at menopausal age. The best treatment is prevention by proper diet, high in calcium, fluoride, and minerals. Osteomyelitis is an infection of the bone. It develops generally after injury, surgery, or trauma. Bone tumors affect form and function. They can cause pain and severely impede mobility. This says other diseases, but trauma really is not a disease. So what I want you to understand here is frequent traumas or fracture is a break in the bone. A sprain is a stretch injury. A strain is an injury to a muscle due to excessive stress. Strains are an excessive stretching of muscle or tendon. Management involves cold and heat application, exercise with activity limitations, anti-inflammatory medications, and muscle relaxants. Surgical repair may need to be had if they have a ruptured muscle or tendon. This is a strain. If a patient is experiencing a sprain, S-P-R-A-N-I-N, it's excessive stretching of a ligament, usually caused by twisting motion. Sprains are characterized by pain and swelling. Management of a sprain involves rest, ice, compression, and elevation. Remember RICE when you see sprain. Rather than a cure or soft injury, the tissue needs to be rested and iced. Casting may be required for moderate sprains to allow them to heal. and surgery may be necessary if it's a severe ligament damage. Disorders of the central nervous system, disorders that affect the motor center of the brain, such as stroke, spinal cord injury, multiple sclerosis, and myasthenia gravis, are some other diseases that may be involved in a patient actually having one of these traumas. They actually set them up for a risk of a sprain and a strain and a fracture. Diseases of other body systems that we might want to consider. Respiratory circulatory fatigue is not exactly a disease, but it can lead to sprain, strain, and fracture. And bed rest reduces overall activity, also leading for a higher risk of fracture, sprain, and strain. Effect on the musculoskeletal system. So we're going to talk about bed confinement. Bed confinement reduces muscle mass by 7 to 10% per week. Osteoporosis changes can occur, leading to possible formation of renal calculi. So basically what happens is the bone starts to be reabsorbed into the bloodstream and filtered through the kidney, causing renal calculi. Impaired balance can occur due to weakness. Foot drop can occur due to immobility or bed rest. Altered joint mobility. If the patient becomes weak and they're not able to move the joints, sometimes they will become stiff. Pathological fractures can happen. A pathological fracture is a fracture in a bone that occurs just on movement, no pressure needed. So for instance, you go in to turn a patient on their side, they could have a pathological fracture to the bone due to you turning them on their side and the bone just being porous and weak. Decreased stability also happens from being bedbound and the increasing weakness of muscle. When we consider fractures, you have to consider the continuity of bone, that, you know, how the fracture has occurred also, and we'll get into that in a few minutes. Some nursing interventions that you want to perform with your patient to help them stay mobile or perform passive range of motion exercises if they are unable to do active range of motion on their own. You want to make sure that you're repositioning them every 2 hours. Encourage independent activity as possible and provide assistance devices if needed, such as canes, walkers, crutches, and also a call light. Effect on the respiratory system. If someone is bedbound or unable to move on their own, they will potentially have a decrease of muscle strength, including the lungs. They may have an increase of secretion because the lungs are not able to expand enough. They may have possible weakness of the throat muscles, increasing aspiration risk. The respiratory depth might be decreased, affecting their ventilation. Their air passages could be blocked if they're not able to cough and deep breathe appropriately. And ventilation capacity in response to exercise will also decrease. In order to increase airway for a patient, one of the things we want to consider is placing them in the semi-Fowler's or high Fowler's position. Nursing interventions, remember to educate your patient to turn, cough, and deep breathe every 2 hours. Provide them an incentive spirometer and teach them how to use it. Use chest physiotherapy if it's necessary. You'll see this often used in a client that might have cystic fibrosis. Encourage fluid intake depending on whether the patient is on a fluid restriction or not. So make sure there's no contraindication. And always assess the lungs, the cough, the sputum production every single shift. Some of the effects on the circulatory system you will see with bed rest or immobility is it increases the workload of the heart, it promotes venous stasis, it can cause orthostatic hypotension, and it causes a risk for thrombosis formation. Nursing interventions that you can help the client with if they are immobile and are at risk for cardiovascular risk are to have the patient up and moving as soon as possible. Assess for peripheral sacral or pedal edema. Anywhere the tissue settles, the fluid will also. Assess calves for signs and symptoms of thrombosis formation. This would include redness, warmth, and tenderness. Measure circumferential or circumference of the calves and compare both sides one to the other. Use TED hose or sequential compression devices to prevent DVT and enhance blood flow to the lower extremities. Administer low-dose heparin when needed. Always ask about allergies before providing heparin to anyone. Effects on metabolism. So immobility affects on metabolism. It causes a drop in metabolic weight. It can stimulate stress responses. It can decrease the appetite. It causes weight loss because of muscle loss, causes bone loss and reabsorption. And then again, muscle mass reduction. Some nursing interventions to prevent the previous. Provide a high-calorie, high-protein diet, vitamins and minerals. Keep an accurate INO and a calorie count. Some of the effects on the integumentary system are going to be external pressure leading to compressed capillaries in the skin, thus leading to ischemia and eventually necrosis. Nursing interventions. Nursing interventions for tissue, you're going to want to change the position of the patient and do a skin assessment with the position change. Ask the client for pressure ulcer risk. So you're going to do a Braden scale and check for pressure ulcer risk. Teach the client to shift weight every 15 minutes if possible. This education is necessary for our patients that are chair or bed bound. Use positioning devices such as a trochanter roll, pillows, hand positioning devices to help with preventing skin breakdown. Assess skin and provide skin protection in the perineal area when needed. One of the things that can occur with immobility is slow peristalsis, constipation, and paralytic ileus. As we are more sedentary, our bowels slow, causing constipation. But a paralytic ileus is a bowel that does not move or is not contracting the way it's supposed to. There's no peristalsis performed on its own. This often leads to blockages and severe infections. So it's important to always listen to your bowel sounds for a patient that is immobile. Nursing interventions. So we want to maintain hydration, We're going to include fruits and vegetables in their diet if they're not autoimmune or have some kind of immune deficit. Promote as normal as possible position for elimination as possible. So you want to make sure that they have good footing, a good height on the toilet. Some of the effects on the GU system can be stagnant urine, leading to increased UTIs and kidney stones. Nursing interventions for the GU system would be encourage fluid intake as necessary. You may want to do bladder training with the patient if they have problems emptying their bladder completely or if they've had a Foley catheter. Assess for urinary retention using bladder scanners. If a patient complains of lower abdominal pain, you may want to palpate and assess with a scanner to make sure they're not having urine retention. Promote urination by pouring warm water over the perineum. Now, this is okay to do with somebody that has sensory perception in the area. This may not be effective if you pour water over a perineal area of someone with a spinal cord injury. Psychological effects of immobility. Of course, it may cause some isolation, mood changes such as depression and anxiety. Some nursing interventions you may want to consider is always involve the client in their own care. They can assist with grooming, hygiene, shaving, and even putting on their makeup. Provide them stimulus with TVs, newspapers, magazines. Involving the client in their daily care and planning the daily routine is ultimately important to keep their self-actualization and self-esteem. Always maintain orientation to time, such as a clock and calendar. So for instance, if you're working with someone that may be in a long-term care facility, not everyone wants to take a shower in the morning. So you may have to remind them that the afternoon has come and it's time for their shower. Nursing interventions, purpose for repositioning your patient. The reason why we reposition our patients is basically to prevent skin breakdown, muscle discomfort. It's to prevent damage to superficial nerves and blood vessels. So we don't want to create any ulcerative areas. We want to prevent contractures. There's different types of positioning available. The Fowler's position, semi-Fowler's, high Fowler's, and orthopedic position. Each position provides the patient a different function. When considering the semi-Fowler's position, it's at least 30 degrees. This is to promote lymphatic return, removal from the axillary, the throat. You want everything to be able to drain. This position is often used for our patients that may have an NG tube. You don't want to lower them any lower than 30 degrees. The high Fowler's position, or Fowler's position, you want to consider this position if they've had like a thyroidectomy. It's to help reduce swelling or edema in the neck area. This position is 45 to 90 degrees. The orthopedic position, as you see, or what we call the Sims position, is it's used for respiratory patients, patients with COPD or shortness of breath. All right, positioning techniques, lateral position, the side lying technique, you see is one hip on top of the other. This position's not used that much anymore. but the lateral position is to prevent pain and bleeding after like a hemorrhoidectomy. The oblique position is another position that we use. Sometimes this position, also called the Sims position, is used for digital, rectal stimulus, or they're looking for a rectal exam. It's also used to take off pressure off the sacrum and the back of the buttocks and hips. The prone position has become very common lately with our COVID patients. It's used for postural drainage. It allows for better respiratory and chest expansion. It creates significant lordosis in the back, so placing a pillow under the hips is a good idea. Never place a patient that's had surgery on the back in this position, though. Like we talked about, the Sims position is for a suppository or rectal exam. It can be used to decrease edema or pressure to the sacrum or perineal areas that facilitates mouth drainage and limits trochanter and sacrum pressure. Positioning techniques such as the supine position is used for mostly our surgical back surgery patients. Dorso-recumbent was when the shoulders and head are elevated on pillows. The alignment should be comfortable position for the patient. And like I said, spinal injury patients. Less common positioning devices and their purpose. The trochanter roll is a roll placed near the hip or adjacent to the hip and thighs to keep the patient from having tilted or elevated hip to one side. A hand roll is usually a washcloth that's used to keep the hand in a neutral position so it doesn't contract. The fingers don't have contractures. Here are some other common devices: the foot board, the cradle boot, and the abduction pillow. The abduction pillow is a wedge used for to prevent internal hip rotation. So this is often used for patients that have a hip replacement. The cradle boot is for patients to prevent skin breakdown on the ankle or the heel because they're bed bound or chair bound. The footboard is to prevent foot drop. Some equipment that we may have to use is a transfer board. Usually these are flexible plastic nowadays, so you can wipe them down. These will be going away from what I'm being told, because we have devices where they're inflatable devices. It takes less work to transfer the patient from one surface to another. Other important equipment that we have to know how to use, and this is very important to understand, is our mechanical lifts and who we would use them on. Now, you would want to use a mechanical lift on someone that does not have the strength to move themselves, so they cannot assist you in any way. These were going to be used on our patients that may have major injuries or weaknesses that, like I said, they cannot help you move from one surface to another. A transfer belt is often used to facilitate walking, transfers from one surface to another, and it's used to hold the patient closer to you and keep them secure when they're moving. There is a right way and a wrong way to place a belt on also. So check that out in your book, because you want to know how to put this on properly. And generally, it is the teeth of the belt. If you see in the bottom part of the picture, it should be face up whenever you're putting the belt on. Tag should be out away from the body. Gait and strength training. A lot of times physical therapy will do this with your patient to make sure that they are able to ambulate and get around, and how much weakness or strength the patient may have. Although what the nurse can do to make sure that the patient does not sustain any type of injury is to always dangle the patient on the side of the bed, to prevent hypotensive episodes, dizziness on standing. You want to make sure that they sit up slowly. You give them a few minutes to kind of adjust to the blood pressure changes. You also want to have them sit up for you on the side of the bed just to make sure that they're strong enough to maintain that seated position before you try to stand or ambulate them. Gait and strength training also, there's some specifics here that you need to understand, assisting with walking. Some patients use a cane for balance. A single-ended with half-circle handle, minimal support, is able to do the stair. So these people are pretty mobile, but they may just need a little bit of help. A single-ended with straight handle is for a person who may have some weakness, but still have good balance. And a multi-prong is better for balance. It's those people that might have a little bit of a wavering gait and they need something to support their balance. Now, crutches are very important to understand for this topic. So when we're considering crutches, some of the things that we need to consider are the type of gait that patient's going to use. All right, crutch walking is an accurate measure of the client for crutches is important. So we need to make sure that when we're measuring our client, it's 2 to 3 finger widths in the axilla space. So just below the axilla, you want to place 2 to 3 fingers, and that's where the rest are for the arm, the resting part of the crutch is placed. When ambulating with the client, stand on the affected side. Instruct the client never to rest the axilla on the axillary bars. There's a nerve that runs underneath the axillary, and if they rest on that, it could actually damage or cause compression to the nerve. Instruct the client to look up and outward when ambulating, and place the crutches 6 to 10 inches diagonally in front of the foot. Instruct the client to stop ambulation if numbness or tingling in the hand starts to occur. Since crutch walking taxes the arms and hands, it may cause discomfort in the axillary arms and palms where the patient is bearing weight. If this occurs, they need to rest. So when we discuss the gait of the crutches, the 2-point gait is used for partial weight bearing. The crutch on the affected side and the unaffected foot are advanced at the same time. So in the 2-point gait, the crutch is on the affected side and the unaffected foot are advanced at the same time. If you're discussing a patient that might have a 3-point gait, this is used for weight bearing and when weight bearing must be avoided. So for instance, if they cannot place weight on that extremity at all, both crutches and the foot of the affected extremity are advanced together, followed by the foot of the unaffected extremity. So first you're going to put the crutches forward, then the unaffected extremity, and then followed by the affected extremity, and then followed by the unaffected extremity. The 4-point gait is used for partial weight bearing. This one, the right crutch is advanced, then the left foot, then the left crutch, and then the right foot. So that one, if you can only imagine, so they're going to move their right crutch forward, then the left foot. So it kind of puts them off balance a little bit. Then the left crutch forward, and then the right foot. That's usually if weight bearing is allowed, and that would be for number 4, the 4-point gait. So remember, 2-point gait is partial weight bearing, 3-point gait is no weight bearing, and 4-point gait is weight bearing. To learn more about these, make sure you look at table 60.2 in your NCLEX review book. And that is it for this slide.